A very good afternoon, my seniors and my dear colleagues. Today my paper would be on a concept paper on using 3D modeling to learn surgeries. I don't have any financial disclosure. So why this 3D modeling? Because COVID has disrupted the physical learning process, as well as computer simulation has been a part of this whole learning process, as we know. But conventional modeling comes with it's a copyrighted discourse. So the hypothesis is cornea has a known geometrical anatomy, known layers. So we tried to make a 3D model. Our objectives are to make a feasible model, a reproducible model, where the tissue properties and disease modeling can be done, and a surgical step discussion also can be done. So this journey of 3D modeling, this is a concept paper. So this journey of 3D modeling is the crux of the whole story. So how do we start? We start with the base plate. This is the base plate. And we go around this axis and make the whole semicircle go around the same axis to form a hemisphere. Now the spherical cornea, we constructed a very spherical cornea. All these are done on the paint software on iPad. Cornea extrapolated from the spherical cross sections. All the semicircles are same in size and 3D rendered. So now the question of primary curve and the secondary curve. So if we have two base plates and we construct two spheres, probably these spheres are going to intersect at some point of time. And if we remove this intervening part, it will consider to be a blend surface. The blend surface is this part. This one is the blend. This is the base plate drawing. So base plate drawings on a 3D model, SolidWorks. Primary 2D drawing, the primary base plate. This is the primary base plate. There's a secondary base plate. And the primary diameter would be 5 millimeter and the secondary diameter would be 7 millimeter. Here is the blend. Now there are different types of extrusion on 3D modeling. There is a cylinder on cylinder extrusion where we form the primary cylinder and the secondary cylinder over that, and we can extrude the final surface to be circular. And we can also do a sphere on cylinder. So the sphere and cylinder, what do they represent? They represent particular layers of the cornea, as we discussed. So layering after 2D image is again a paint image. So if we can think of a sandwich, so 3-layered sandwich, and all the layers will have some kind of adhesive properties in between them. These adhesive properties can be implied on them, and we can simulate different disease or normal physiological processes. And now if we can mold this sandwich into a spherical area, it will almost learn to a cornea. Coming to the materials and method, is a concept paper. So basically we had only 9 PGTs and 4 seniors, given some normal 2D pictures and some given 3D models. 10 hours, as for all simulations, hours are important. Post-learning multiple response method we have used. So multiple response method is a proxy method. Social research method is a pilot project. Semi-quantitative and multiple regression analysis have done. Parameters could be acceptance, simulations, reproduction, and shareability. So the results are, we are trying to compare the conventional 2D images of the books or PDFs, whatever we find. And with the 3D models, we are sharing on different platforms with the persons, the 9 PGTs and 4 seniors. So the acceptance level is definitely quite high because it is shareable. And if we go on to the simulation part, we'll see that the primary acceptance level is quite low. But as the cumulative frequency goes up, the acceptance is more. The simulation is getting more accepted with time. Now this reproducible learning, is this reproducible or not? The cumulative frequency shows that it is reproducible in case of 5. Now this is a pilot project. This just gives a crude idea. And shareability, definitely it's shareable across the platforms. The discussions would be that the models are accepted over hours, and pilot proves prospective terms for the same. Comparison with conventional modeling like drawing, oral lectures, and observational learning is required, because just making a model, making a 3D model is already available, although it's a marketed model. But we want to have a free model. And then whether the acceptance of free model is there or not, it's more a SRM, social research method, but we need to find out that. We tried to find out that. Acceptance can be graded with controls. Softwares needs upgradation on dynamic modeling. This is again a part of discussion. As whatever I have shown is a static modeling. So a dynamic modeling is when you apply force, a surgical force on the cornea, it tend to get deformed. Now, if the model simulates the deformation, it will be a dynamic modeling. We need to incorporate that part into our model. Application better be tried. Participants mostly used over mobiles. This is again a factor because mobiles doesn't give you an equivalent platform for all the participants. It has to have same software, has to have same Android or same iOS platforms. Layers can be, microscopic properties can be modeled within the layers. Adhesions differ in strengths. The cheese separation technique can be used. So the layers, the cheese can be molded into a spherical layer as well. They can be compressed and they can be distracted from one another. Printing on nozzle technique can be considered with the PDMS, but bioprint can also be available. Can also be made available. 3D modeling on cornea is quite effective. The conclusion would be versions to be better. This is just a version probably 0.1. It is quite a new arena and a bright zone to improve on the qualitative learning and assistive learning. This is my bibliography and thank you.
Thank you, Dr. Ghosh. Just to be on the lighter side, I think to design something as complex as this, you need to be a person good in physics, chemistry, artist, sculpture, and so many other things. I think you managed to do all of them. Sir, you would like to ask any questions?
Is it a real thing or a hypothetical one? Meaning to say it is a molded, ready to use one, or it is just a hypothetical
Sir, there's a whole process, the whole project going on. This is just a part of the project. The first version, it's a simulated 3D version over the softwares. The next version, it can be 3D printed. Now this 3D print can be an artificial print, can be a bioprint. So the first the model, acceptance of the model, then bioprinting, the artificial printing, then artificial printing, PDMS structures, different layers, and then probably bioprinting. And bioprinting over a fixatives. So it could be fixed and can we simulate the AC2? That's the whole idea, sir.
What is the advantage with your proposition,
Sir, the idea is if we are scanning the patient, we are seeing the patient before we operate on a patient. We are taking the simple cataract surgery. So we see the patient, we simulate the patient, we practice the surgery, then we go to the original surgery. This is the basic idea. And we try to, this is not going to be acceptable with conventional mode of teaching.
Yes.
So we want to introduce into the learning process for the PGs, for whoever learning a surgery. Then if accepted, then it can be done in a personalized surgery. Like we are having personalized medicine. Why can't we have a personalized surgery? But for having a personalized surgery, we need to simulate that. Only after the simulation, we can tell, okay, this is going to be my complication. So I need to be very worrisome or I need to be very cautious about this complication. This is the basic idea, sir.
Okay. Forgive my ignorance, but I still fail to contemplate what you're saying here. How does it exactly help the surgical practice? Because you're doing it with the help of a software.
Yes,
so
sir.
If it is printable, if you have the whole 3D model with you,
yes,
then maybe you can actually do it.
Yes, sir.
But when you have eyes that present you a coronal picture of the whole thing, then how does the 3D model differ? I mean, what are you trying to teach your postgraduates based on that 3D model? I still don't understand how is it going to, for understanding, identifying layers, understanding the elevation maps, it's superb. No questions asked. And I really like the originality of the concept. But how does it actually help the surgical training is where I'm missing the hint.
So it's a dynamic modeling. Like in my discussion part, I have mentioned a limitation. It has to be a dynamic modeling. So as I go through my stylus, it creates an incision over the cornea. Now the cornea is getting breached. So the model will accommodate the breach. It will show off the layers. Now if it is suppose it's an early entry or a delayed scleral entry. Now how will the cornea behave in both the cases? It can be simulated over the 3D modeling. Now when a learner is doing the surgery on a live eye and on a 3D modeled eye, when it's a dynamic modeling, he is going into and making the incision, making the faults there and understanding, okay, cornea somehow behaves like this. In fact, this is an idea taken from the robotic surgeries. In all other streams, robotic surgery is coming and distant surgeries is coming. But distant surgeries have been already tried. But in eye, distance surgery has to be very fine. So all the layers have to be perfect. That's why we are trying to have a 3D model where the dynamic model can show us the deformation, the changes as we apply force or as we apply cut or surgical incisions over a tissue. That's what we're trying to model. It's a dynamic modeling. This is just the first part of the whole project, sir.
Is it not akin to the simulations? No.
Sir, is just not a simulation. The dynamic modeling is more than a simulation. So if we can model how a cornea or how a tissue is going to behave when exposed to an external force, then only we can, like bioprint, we have already bioprinted corneas. We have bioprinted scleral layers. We have bioprinted capsules, the lens capsules. But what we lack there is a simple series of cells. But this series of cells are just not for there with the simple adhesions. There are so many ion channels. There are different adhesive molecules are there. So exact bioprinted cornea doesn't act like a normal cornea, because we miss those adhesive properties. We miss those typical tissue properties. These are macro properties. These are not micro properties. So we are trying to make a 3D-dimensional model where these macro properties will be simulated or emulated too, so that a model would be so perfect that it can actually simulate the tissue properties of perfect cornea while giving such an incision. This is a distant dream. Probably version 10 or version 12 will be like that. But the basic idea is to reach there. And we started with simple cataract surgery, simple corneal incision, rather leave cataract surgery, sir. Simple corneal incision. Can we emulate the tissue properties, the resistance we are feeling in the cornea? Can we show that while we practice the simple scalpel scratch over a 3D model?
Corneal properties, if you have an incision, say, placed to the wrong plane,
yes, sir.
Or if it's not a triplanar or the length of the tunnel is short or long, whatever it is, the properties actually change or inflict on the clinical manifestations come in after they heal. They do not produce an immediate change in the structural property of the cornea.
How much force in a cornea would produce a early entry? How much force or where the force has been applied? The amount of force and the place of force. That we want to emulate. This is going to give you a wrong incision, a wrong entry on that particular cornea, or not each and every cornea. On that patient's cornea, this incision at this point of time.
Okay, so you mean that you would have a 3D graphical representation of each individual.
Exactly, sir. Exactly. Personified surgery.
That's interesting. Yes.
And nothing to do with the hysteresis, no?
Sir, there are so many properties. My presentation is just from the concept paper. So a corneal property can be on different lines. It can be static property, it can be dynamic property, it can be ASOCT, it can be hysteresis. There are different diagnostic properties. What is problematic is that it has to be wholesome, at least 90% of the normal cornea.
Yes.
That's what we're trying, sir.
Okay.
What we could probably understand is that you can have a dynamic simulation of, in most of the cases, a normal cornea to an external force, how it behaves.
Yes, sir.
But when you are operating each cornea, each set of structures is totally different.
Exactly, sir.
So it is, the possibilities are infinite.
Exactly, sir.
And how would you plan to create such an infinite possibilities in?
Sir, we are using
something very difficult to comprehend. Because you can probably, in maybe 70-60% of the cases where most of the corneas behave in a typical fashion, maybe this dynamic simulation would work out. But there are many set of cases where probably, it really doesn't act according to what we expect.
And you'll also
the situations are different.
Yeah, you'll also have to find out a way how to extrapolate the
Exactly.
quantified real-time force
Exactly, sir.
into the quantified
Exactly, sir.
virtual force. So how would you tell your student that this is the amount of force? Because the force is not measurable. You are entering with a blade.
So the stylus, we have tried to titrate a stylus with the amount of force on a particular screen. So a particular software, a particular base with a particular stylus that gives you the amount of force in the direction of the force and the back. Like we have a display on the FECO machine. So this is the amount of force. So on the amount of stylus, as normally the touch screens work like that. They give
on the virtual platform, what you're saying is fine. But when the hand actually moves in, you don't have a stylus there.
Yes, sir.
You have to
definitely
do a lot of work there, but
definitely
as sir has pointed out, the potential is quite immense.
And the manifestation, we are trying to have a predictability model. There are so many predictability softwares through AI. We are working on that, the predictability models. So.
Right. Thank you.